I'm Greg Leckleitner from Los Angeles County Department of Mental Health. I'm the chief over our Child Welfare Division in the Department of Mental Health, which was a position created specific to KDA. We have a similar position and a division in our Department of Children and Family Services that are kind of our counterparts there, and we've been working on KDA for a number of years here. Me specifically, been working on an everyday basis, working with KDA and systems reform between mental health and child welfare, probably most deeply since 2005. I'd say those past 8 years. I've probably gotten 15 years older. It's been a big process for us, and I'm sure you're all experiencing at least some of that right now. I'll let my colleague introduce herself.
Hi, my name is Darlene Horn, and I'm a health program analyst. I am the Children's System of Care Bureau analyst, so I basically coordinate all of the funding and of the KDA programs and other children's programs within our bureau.
So as many of you probably know, the plaintiff attorneys in this case brought a suit, a class action lawsuit against both LA County and the state of California back in 2002. LA quickly capitulated. In 2003, we entered into a settlement agreement with the plaintiff attorneys. What that did was create a identification of a class of kids who were entitled now to receive these Medi-Cal benefits. Created a KDA advisory panel, which still works with us to this day. And also attached to that panel is a group of plaintiff attorneys from around the country who also have been meeting with us and working with us over these many years now. So we're very close to the legal action, maybe more so than some of the counties might feel here, because we have this panel and a group of plaintiff attorneys who are working with us on planning and evaluating everything that we do. So KDA for us now, I mean, in the early years, we really talked a lot about KDA, and there was a lot of references to what we're doing with KDA. That term, that brand is kind of beginning to dwindle over the years, and I think in a sort of a good way, because this is more than just about the lawsuit. It's really about a systems reform issue that's going to go on long beyond the lawsuit. And really is about systems integration. And again, more than just about services, but we found that trying to provide the services that kids in the child welfare system needed, we in mental health couldn't do that by ourselves, and certainly child welfare couldn't do that by themselves. And we've really had to spend a lot of time, and we're still in somewhere in the middle range of developmental process on this, but it's really required us to sit down together to think about our entire systems and how we can work better together. So for the county case, in some ways really around two different things. One was improving access to mental health services for kids in the child welfare system. The logic of KDA was that kids in child welfare who had mental health needs were not being systematically identified in any kind of way. They kind of made their way to mental health services through random kind of willy-nilly processes that oftentimes were individual to individual social workers, their understanding of the service systems, which of course are quite complex. So oftentimes the needs were not identified at all. And secondly, when the needs were identified, that the kind of services the kids really needed to produce better child welfare and mental health outcomes were not being provided. So we've been working on both access and service quality now, and focused initially primarily on service access. So the system we've set up in Los Angeles, and again after much kind of debate and thinking about this from lots of different people, so unlike what you've heard from other counties, we basically have our social workers from DCFS doing the initial mental health screening. So part of that was driven by the fact that our system is so large. We have about 58,000 kids in the child welfare system each year. The number's going down, but it's still a very big number. And the county's also very big, covers 4,000 square miles. We have 19 DCFS offices. So there's a lot of territory to cover. And so the decision was made to have the social workers actually do the screening. We initially used the CIMH mental health screening tool, which some of you may have seen. It was developed maybe 10 or 15 years ago, probably 15 years ago now. Had a 0 to 5 version and a 5 to adult version. Really was created primarily for the purpose of a non-mental health professional doing an initial screening. We started with that tool after looking around the country and not finding much that was looked much better to us. And then over the years, we actually have done some adaptations of that to increase sensitivity. So at this point, we feel like we have a pretty good tool that makes sense for us for both 0 to 5 and to a 5 and up population. We're working with USC School of Social Work now, and they're in the process of validating that screening tool to see if in fact it does predict the need for mental health services. We also co-located mental health staff in all the 19 DCFS regional offices, so we have almost 300 mental health staff now who are co-located across the county. Those are clinicians who take the referrals from the social workers who are doing the screenings. I should mention that, again, in the early days of this, that we saw it was important not only to do the screening, but to try to get the services in place as quickly as possible. So the social workers are not only doing the screening, but they are also obtaining consent for services and authorization to release mental health information. So that comes to us with the referral, along with a document that attests to the benefits establishment, that these kids are, for the most part, EPSDT eligible. So we get a packet from the social workers that says, this is a kid who's screened positive, he or she is EPSDT eligible, here's the authorization to begin to provide services, and here's the authorization to release information. That comes with a referral form, and oftentimes the documents from the court for the child who's referred to mental health, and we start with that, and then for the most part, we're doing triage work, kind of quick identification of which kids need to be seen most quickly and what kind of services kids need, and our co-located staff refer those kids to our broad network of, we have 78 children's mental health providers across the county and 8 directly operated children's programs. So there was also some need to do some enhancements, again, not total change, as has been talked about. This wasn't starting from scratch by any means, but the system had in some ways evolved over the years before this lawsuit, so that the common practice was you had outpatient mental health clinics for kids. Kids were referred to those clinics. This is even pre-MHSA days, of course. The kids were referred to those clinics, and there was a fairly cookie-cutter approach to, we're going to do once a week talk therapy. You're going to come to my clinic and be seen by somebody. If we think you need to, we will send you to a psychiatrist who might do some medication management. And that was pretty much what most kids got. I mean, there was some variation in that, of course, but that was kind of the standard. So the folks who brought the lawsuit recognized, of course, that that was not the kind of services that most of the kids in the child welfare system were going to benefit from, and contributed somewhat to the poor outcomes that kids in child welfare were having. So they really have pressed us and continue to press us to have a system that is much more a system of care kind of an approach, a true systems of care, to have services being delivered in the home or field-based services, to have services being much more individualized, services being much more provided by sort of non-professionals as well as professionals. And so that's the way our system has been moving over these past couple of years. And we, like the state case, put together a shared core practice model, which we are still working on. It starts with a sort of what we call the LA County vision and mission, a set of practice principles, and then ultimately a core practice model, which really defines the way that individual workers on the front end of both systems are meant to engage families, to think about their strengths and their needs, to work together, to track service progress and outcomes for kids, to make adjustments as necessary, and to transition children and families out of our systems entirely and back to their communities where they, where the best services and supports are really going to be located. We also establish a set of data indicators, so we are tracking progress as we go along over the years. These primarily are indicators on the child welfare side having to do with safety and permanency and stability. We've also added well-being. So we are tracking on a regular basis our progress in improving these kinds of outcomes for kids. And this is something we share with the panel and the court on a regular basis. We also have invested a significant amount of energy and resources into a quality improvement process. And we ultimately adopted what's called the Quality Services Review, which has been used in several other jurisdictions around the country who've had similar kind of lawsuits. This is an interesting process. As the name suggests, it's very qualitative. You take a look at a small number of cases, in this case from each of our offices. We do the office by office. You have a team of people from child welfare and from mental health who use a protocol that allows for scoring on a number of dimensions, most of which look like systems of care dimensions and outcomes for kids and families. And you look very deeply at individual cases. These reviews take 2 to 3 days per case. They involve interviewing all the people who have been involved with the child and family, the social worker, the supervising social worker, the mental health folks, the probation folks, the children and the family, any extended support folks in the community who have been involved. And based upon that review of the case, you decide whether, in fact, what it is in some ways is a fidelity measure to the core practice model. So is, in fact, what we're saying we want to do being put into place and working with individual children and families. And this is so important to us that it's become part of our exit criteria from the lawsuit. So we don't exit the lawsuit until we show that we've actually are doing core practice model with some fidelity. As part of the service integration, we've had to spend a fair amount of time developing mechanisms, processes, structures to work together and to talk and plan together and to evaluate together. LA being a big county, we had large institutional silos that have kind of operated over the years. Huge Department of Children and Family Services, huge Department of Mental Health, their own kind of ways of looking at the world, their own information systems, their own funding sources, and there was not a whole lot of work together between those two systems. And so we've had to spend a lot of time thinking about how we can bridge that gap. So we developed shared management structures over the years. So our directors and deputy folks get together on a monthly basis, along with our chief executive office in the county, and we review our progress and plan for going forward. We, as I said, we have the shared core practice model between the two departments, which also includes probation. We have a set of shared performance targets, so we're all trying to move in the same direction. We have the shared quality improvement methodology that I talked to you about, so this is both for child welfare and mental health. We spent a lot of time working on a shared information protocol because, again, we realized in the early days that we couldn't really talk much about our progress or even what we were doing if we didn't have some way of sharing information. Ultimately, the plaintiff attorneys and our county counsel went to the judge in the case and asked the judge for some authority to begin to share information. And the judge signed an order that allowed us to do that. That's been very helpful, I think. And at this point, we do weekly data matches of all the kids in child welfare and all the kids who are receiving mental health services. And we can identify fairly closely which kids in DCFS are getting mental health services and what kind of services they're getting. So that's been very helpful to us. And we have a shared financial commitment, so which we're going to talk more about. And let's see. I think this is where I turn it over to my colleague.
So LA County has been successful in integrating what is sometimes a very complicated system of several different funding streams, but we do braid funding streams for implementing all of these programs. Full implementation cost of $190 million is what all of the programs combined cost overall. Among that number, we have Medi-Cal funding that is available to all EBSDT eligible clients. We use Title IV-E money, Mental Health Services Act funds, our Prop 63 funds, and of course our County General Fund. So we do have a joint financing structure because we have all of our different departments involved, DMH, DCFS, CEO. We do conduct monthly shared budget reports, mostly between DMH and DCFS. We meet monthly, both by conference call and in person, to discuss our financing structure. We have joint finance meetings, and we also have joint contracts that are directly operated as well as contracted out to our providers. And those joint contracts include wraparound services and treatment foster care services. So under our, we do have an MOU structure where we do have an agreement with DCFS about what our shared responsibilities are. That MOU was finalized in 2009, and it basically outlines the services and responsibilities that are to be provided by each department, the staffing and infrastructure that is needed by both departments is outlined in that MOU, and it also identifies what services should be provided by each department. Those services would include training of staff, consultation, and direct services to clients. So the funding, what does the funding support? It supports program expansion. For our wraparound program, we have 4,200 slots. Those services to the kids in those slots are provided by 34 wraparound providers. The cost of that program is $102.5 million, all funded by Medi-Cal EPSDT funding. We have our multi-assessment treatment program or services that are provided by 52 MAP providers for a total cost of $17 million EPSDT Medi-Cal. And we have our enhanced mental health services, which of course doesn't cost $71. We left off the M, that's $71 million. We wished it was $71. But that $71 million is equally spread, almost equally spread between our directly operated DMH clinics and our contract providers, so our legal entity providers. Within that enhanced mental health services, we provide treatment foster care. So there are 300 slots of treatment foster care clients, 300 slots that provide services to treatment foster care clients. There are 12 providers that provide treatment foster care, and the total cost of that is the $12 million, which of course, again, comes out of the $71 million.
So we've also done some things to try to mitigate costs here. And Affordable Care Act talks about this idea of hotspots, for example, which is trying to identify those places in your system where you're spending a lot of money and probably not getting a lot of bang for your buck. Those areas in our county are typically been for psychiatric hospitals and ER rooms where children and families end up kind of at the end of the line when the rest of the system hasn't worked very well for them. So we developed an urgent care center resource for kids in the child welfare system to, as a place for them to go rather than going into a psychiatric hospital. So the urgent care center serves about 800 DCFS kids a year who can spend up to 24 hours there and receive mental health services, crisis stabilization services. It's also been very handy as a medication evaluation and management resources because I'm sure like in your county, our kids in the child welfare system move around a fair amount. And whenever they move, there's oftentimes a service breakage. And kids who are on medication may run out of medications. They may go to a location where medication isn't easily available, confusions about what medications they're taking, and so forth. And so the urgent care center on a daily basis sees, I would say, 5 or 6 kids every day who are coming in there just to get their medication, to see whether or not they need medication and to update or refill medication prescriptions as they're needed. We also invested some additional resources into our psychiatric mobile response teams. So we have 24/7 crisis mobile response teams in the county who are available to go out when they get a call to our centralized access center number when there are questions about whether or not an individual needs to be hospitalized. With the work with KDA, we quickly found that we needed to have them become more responsive to the DCFS kids than they historically had been. It had been a priority, but we still weren't getting to kids as quickly as we felt like we needed to, and in some cases that would end up resulting in a hospitalization or another adverse outcome. So we staff more people in the psychiatric mobile response teams now, so they go out KDA, the DCFS kids are their top priority. They see those kids more quickly than they see anybody else in the county, except for, otherwise kind of obvious emergent situations. High priority for them. They make over 1,200 calls, 1,200 visits a year to see kids in the child welfare system at this point. We also developed a joint response protocol, because what was happening, of course, was you'd get a call for the psychiatric mobile response team, and they would get out to a group home or a foster family home or a foster home or a parent home, and cases where there were open child welfare activities and really needed to have communication with child welfare. So we set up a protocol by which whenever they're called out on a case involving a child with an open child welfare case, child welfare is notified also, and whenever possible, they go out together. So during the daytime, for example, if our PMRT team goes out, they also call the social worker and say, come along, we need to work on this case together. It's more difficult in evenings and weekends, but there's still a contact between child welfare and mental health on each of those psychiatric mobile response team calls. I mentioned the information sharing. So what we've done now is we've kind of moved beyond just being able to do reporting out and show progress and so forth. So each week now when we do the data match, we send a file over to DCFS that shows that these are the kids in your system who are currently getting mental health services according to this data match. DCFS parses that out, so each of their social workers is given an email and says of the 30 kids on your caseload, these 15 kids are currently getting mental health services. Here's who the provider is. Here's the contact number for the provider. Here's a hyperlink, so if you want to know more about this child's history, click here, and you can go in and see the child's whole mental health history in terms of each episode, not diagnosis, but who the providers were, what the length of the episode was, the kind of services they received, and so forth. So. And we're working on a process right now where we're going to kind of move that information the other way so that our child mental health providers will be able to go into a system and identify which of the kids that they're serving have open child welfare cases. We should have that ready to go in another few months. And much like the recent state legislation, we've also done a lot to try to keep young kids in particular out of group homes. So about a year or so ago, DCFS developed a policy by which for a child 12 and under, you'd have to get the director's sign-off in order to put that child into a group home. And that's created a lot of sort of pushback into the mental health system and sort of an urgency for us to provide services and supports as quickly as possible. So for us, scaling is always a big issue. Getting things up to scale, because it's just the job is so the job is so enormous. So Darlene mentioned that we've done a lot of work trying to expand contracts. So we had existing contracts with our children's providers and we work with our directly operated programs. So we put money into those systems to try to increase their ability to provide services to kids in DCFS. So kids could get access to services more quickly. We also have developed this kind of monthly tracking process so we can see, again, how we're doing with that in terms of our providers using their allocations. Are they seeing DCFS kids? Is there less wait time for DCFS kids to get services? What kind of services are they getting and so forth? What kind of outcomes are happening? In the early years, and even in some more recent years, although we put a fair amount of money into the system, our $190 million, we found that the system couldn't quite choke that down quickly enough. So we ended up having savings. Much of that savings was related to our expansion of our wraparound program. So the state case talks about the subclass, and we didn't have a subclass in our county case, but we were talking about the same kids without calling them subclass members who needed this kind of more intensive systems of care wraparound approach. And so we thought the way to do that was to expand our existing wraparound program, which was already quite large. We had about a 1,400 slot wraparound program. We said, let's increase that to a 4,200 slot wraparound program. And we established some benchmarks by which to increase that every year. And that's historically been slow and kind of capped out around 2,200. So right now we have 2,200 kids in wraparound. And because we've funded the program to serve 4,200 kids and we're only serving 2,200, we have a lot of so-called savings or unspent dollars, dollars allocated but not spent. And particularly on the case rate side. So Darlene mentioned our wraparound program, probably like yours, is funded with some EPSDT, but also there was a significant case rate. In fact, in the early days of our wraparound program, it was entirely a case rate funded program, and now it's moving in a little bit different direction, which I'll talk about later. So we actually ended up putting money into what we, at least in LA, call a provisional finance unit. So these savings, which were as much as $20 million in some years, would go into this unit, which then basically would evaporate because it was considered to be one-time money at that point. So it didn't roll over to cover future years, and so it ended up being money that just went to waste in kind of a way. It prompted our director at DMH to issue a memo back in 2010. The memo basically said, look, we've given you money to do wraparound, to do treatment foster care, to do our MAP program, to do enhanced services, but if you can't spend that money doing RAP or MAT or treatment foster care, and you got a child welfare kid, spend that money providing services for the child welfare kid. So we're not just having this huge savings every year. And so providers have kind of moved away from just spending their wraparound money to do wraparound, for example, to spending it for provision of other kind of mental health services for DCFS kids. We needed some flexibility there. Let me give you a sense of what this is costing us now. I mentioned access earlier, and I think we've done a really good job improving access. And so I'm using some fiscal year 11-12 data here. The 12-13 data is still a little fluid with claims coming in, but for the 11-12 data, about 70% of the kids who had open child welfare cases, in our case that's over 40,000 kids in LA, received mental health services. And that was up from 28% when we first took a look at this back in fiscal year 04-05. So you can see there's been a good jump there, I would say. And the cost of those services for us for fiscal year 11-12 was $240 million. And that represents about 42% of the cost of our county for serving folks under age 21. So it's a big part of our service continuum. Which brings me to the state case, settled in 2011. Again, the same judge, the same federal district court judge, the same attorneys, so a lot of the same kind of emphasis on the fact that there's Title 19, provides for Medicaid, Medi-Cal here, and people who have access, people who qualify for that service need to have it, and if you're not getting it to them, that you're sort of violating their rights, and you're not getting EPSDT to where it needs to be. The state case, as you've heard, talks about a core practice model, again, very similar to the county's core practice model, and that was done intentionally because the judge was cognizant of the fact that he didn't want to have LA County having a core practice model and the state having a different core practice model. So much of what came out in the state case as a core practice model came from the LA County core practice model. Really talks about these two services, intensive care coordination and intensive home-based services, and these being services that are now entitlements to members of the KDA subclass. It's been interesting because, again, we're talking about the same attorneys in both cases, and a lot of the intentions of the panel, in our case, being very consistent with the state case. So when we first got the green light, like all the other counties in California, that we needed to get out there and start doing ICC and IHBS in the core practice model, we put together a pretty aggressive plan to say we need to get these services out there to a lot of kids, and quickly. And we were initially pushed in that direction in part by the plaintiff attorneys, but when we began to get going, they said, wait a minute, slow down a little bit. Their concern was that we were going to be asking a lot of our providers to provide ICC and IHBS to KDA subclass members, and that might begin to show up, for example, in their information systems. But what would be really the quality of that service? They were concerned about service quality. So they asked us to slow down. So we've kind of got two directions now. The state, of course, anxious to see that ICC and IHBS are getting some traction, getting off the ground, as are we. At the same time, we want to make sure that we do that with some fidelity, some quality, so it's not just a bunch of claims. And it's really services that are what ICC and IHBS and the core practice model are intended to be. So we have now begun to roll out ICC and IHBS within our wraparound program. And of course, these are services that are not foreign to wraparound providers, but thinking about them as ICC and IHBS is a new idea. Our treatment foster care program is now doing ICC and IHBS, and this again, not something that was historically done in a treatment foster care program, particularly this idea of a child and family team. So that's a new concept that they're getting their heads around. And then we put together this intensive field capable clinical services program. And that idea was, again, to target these hot spots with really intensive care coordination and intensive home-based services. So our intensive field capable clinical services program is meant to be a rapid response system to kids who are coming out of psychiatric hospitals, kids who are being referred to the urgent care center, kids who are coming through our psychiatric mobile response team process, and those kind of places in our system where those kids that were moving around with high needs and oftentimes having a hard time keeping services in place. So when our providers agree to take those cases, they follow them from wherever they go. So if the placement changes, they follow them. So they've been following some kids, from one end of the county to another, in some cases kids moving out of the county. And so that's been a very interesting program, funded with mostly EPSDT, a little bit of county cost, and a little bit of MA funding, but probably 90% EPSDT. And it's been interesting to see how much use they can make of that funding source. These numbers might be helpful in terms of thinking about what this class and subclass looks like. So for us, looking at our 2011-12 data, again, having about 58,000 kids in the child welfare system. 26,000 of those kids were class members, according to our data. That's about 44% of the total DCFS population. And I think that number's probably a little low. I think that number's going to end up being a little higher as things continue to move along. It's about 25% of the entire DMH population who are under age 21. If we look at the subclass criteria, ends up being about 8,000 of our kids met the subclass criteria. That's about 14% of the child welfare population and about a third of the class. So I'm guessing we're looking at something here which probably approximates what we thought we would be doing when we first got involved in this, which back in the early days trying to figure out what the service needs of this would be. And we kind of projected, working with the panel, that about half the kids in the child welfare system or more would be class members, and there'd be about a third of those kids who would need to be receiving more high-end services consistent with kind of a wraparound approach. And then what do these services cost? So again, here the thing that's probably the most interesting is just the kind of the service cost per client as opposed to the total. But if we look at kids who are in the class and the subclass, that's about $9,000 per child of mental health service, of EPSDT service. Kids who are in the subclass only, again, these are the kids who have the high-end needs, we were providing about $19,000 of EPSDT a year of service for those kids. Kids who are in the class only, so these are kids who are class members but not subclass members, it's about $4,000 or $5,000, about $5,000 a year of service is kind of the baseline, is kind of an average mental health service cost for kids who are in the child welfare system who are not subclass members. And that compares, if you compare those numbers to our wraparound program, you see that the subclass members are getting a pretty similar kind of level of service that kids in our wraparound program are getting, which kind of makes sense. So where do we go from here in LA? So our strategic plan, which was meant to be our kind of grand plan for moving forward, was back in 2008. We're currently in negotiations with the plaintiff attorneys and the panel members to update that plan. So we're looking at everything we've done, looking at our wraparound expansion, our MAT expansion, our treatment foster care program, the idea of how we're setting up our screening and triage system. That's all kind of up for grabs again to see if we want to make any changes in that. And we're particularly looking for ways we can shift some financial commitments from one place to another, where now we think maybe these costs are needed somewhere else in the system, whereas maybe 5 years ago it made sense to put them here, but now they may be better used somewhere else. we are very much involved in trying to find a way to increase our coaching capacity. So the core practice model, we've done tons of training with both child welfare and mental health, some integrated trainings with child welfare and mental health around this core practice model. And that has moved practice along a little bit, but not nearly to where it needs to be in order for us to do well in our QSR, for example, or to say that we have in fact integrated our two systems to the point where there's some degree of being okay about that. And I think everybody agrees that it's going to be this more intensive coaching component on a case-by-case basis, real-life cases in the field, with a coach who has had experience with the core practice model and kind of thinks about this in a different kind of a way. They work in a different kind of a way. We have on the mental health program, we have 3 coaches for the whole county. DCFS has 6 coaches for the whole county. So given the numbers you're seeing here, you can see that that's not going to get the job done. So we are, I've had some conversations, in fact, here today. Our DCFS director has been chasing us down the hallways and saying, why aren't you guys using 4E money to do some of this work? I think that might be a funding source for you. So we're going to explore that, and there might be a child welfare funding source here that could be used to fund both coaching for child welfare and for mental health. We're also looking for additional resources in our quality services review process. So as I mentioned, good scores on the QSR, which is going to be, again, fidelity to core practice model and good outcomes for kids and families, is an exit criteria for us. The state case has an exit in 3 years. They went from 2011 to 2014, and that case right now is slated to exit. Our exit is based upon certain performance indicators which are contained in the QSR and elsewhere. And so the faster we can do the QSR and move through our system, the quicker I think we'll be able to show that we've made some progress. And so we need to accelerate the pace of our quality services review process. We are also right now just getting underway with an RFSQ process for our large wraparound program. And this has been a really interesting journey. The wraparound program in LA initiated in the child welfare system, and as I mentioned, funded entirely with child welfare dollars early on, then some combination of mental health and child welfare with KDA, and particularly with the state settlement. Our feeling was we ought to be doing more of this work using EPSDT and less of a case rate. Our providers aren't too happy with that idea. So in some ways that they feel like that puts more risk upon them. Of course, it's easier to provide a service with a case rate than with an EPSDT knowledge, which has lots of documentation standards and more audit risk. But we think that the spirit of KDA, the whole lawsuit, is about these kids being entitled to EPSDT mental health services, which are required to meet the terms of the settlement agreement. So that's where we are headed at this point. Our new wraparound program, the contracts will have specific language in them around ICC and IHBS, of course, and the core practice model. In fact, we're preparing a service exhibit to amend all of our children's contracts to say that if you are serving a KDA subclass member, these kids need to be getting ICC and IHBS, and for all DCFS kids, you need to be performing consistent with the core practice model. That's going to be contract language. I'm also waiting for our director to sign a new memo that's going to undo this flexibility idea, so that our providers now are going to have to sort of operate consistent with their contract. So if you've gotten a wraparound dollar, we want you to do that. We want you to spend that dollar doing wraparound, not doing something else. Same with treatment foster care and for MAT for us. So we're going to have to kind of shift the utilization of those dollars back to their original source. We're going to be continuing to promote the core practice model in any way we possibly can. And obviously moving forward, as the rest of you, to try to get ICC and IHBS into place. We also have in Los Angeles County now, we have a Blue Ribbon Commission, which was appointed by our Board of Supervisors, that will become a player in how this all kind of moves forward for us. This is a commission of 10 individuals from around the country who are examining our child welfare and by connection here, our mental health system in terms of providing services to kids. That commission is slated to make some recommendations to the board later this year, and that may, again, move us in some kind of a different direction. So it'll be perhaps a competing, or hopefully not too competing, but an aligned agenda for how we can go forward from here. I think with that, I'll stop, and Troy, we can take some questions, bring people up.
Yeah, that would be great. Thank you
Okay.
very much. Let's give
Thank
LA
you
a
all.
hand. Great presentation.